So thank you very much for the invitation to be here. And I'm an infectious disease physician and clinician scientist at the Jewish General Hospital at McGill University in Montreal, Canada. I work in an institution that serves a very diverse population, and 65% of our population are foreign-born. And so my clinical practice and my research are both focused on migrants. And we see a lot of migrants in our practice. So I was asked to talk about the big picture of why and who we should screen for viral hepatitis and other chronic infections. So I'm going to go a little bit beyond viral hepatitis and sort of just try and paint the context of what migrants have just in terms of the burden for infectious diseases. So what I want to cover today is I want to go through some migration trends to sort of set the stage of why this is an important issue. I'll talk about some of the health disparities related to infectious diseases, viral hepatitis, but some other infections, infectious disease screening and the rationale and guidelines, and then some of the implementation barriers and facilitators. And then I'll focus a little bit on hepatitis B and C and some best practices and challenges. And as mentioned, this will be a relatively high level overview. And I think that this afternoon, or a little bit later this afternoon, there's going to be a little bit more on the ground implementation and what people have been doing in Switzerland. So global migration is a phenomenon that's been going on for centuries, and it has been driven most recently by human conflict and natural disasters. And as you can see, the Vietnamese boat people in the 1970s and the Syrian war and now the Ukrainian war have been fueling migration over the last several decades. And so there are 281 million migrants in 2020. This accounts for 3.6% of the global population. And the number of migrants has tripled since 1970. And I think that what has really brought this issue to the forefront in the last 10 years is a global refugee crisis that in the last 10 years, the number of refugees has doubled. And in this last year, the number of refugees is over 1 million and greater than the numbers since World War II. And this has again been fueled by conflicts most recently in Ukraine, but in other places. And in Europe, Europe has been particularly affected and involved in migration since 2015, when there were 1 million migrants that came into Europe in 2015 and 16 related to the Syrian war, with a lot of other people who came from Africa and other countries in addition to the Syrians. And so these are some of the images from 2015 and 16 that people are very well aware of, the large number of people that came into Europe. And so as a result, that the total number of proportion of migrants living in Europe is at 11.5%. And you can see the number that are in Switzerland and Germany in Europe leads the number of migrants living, or proportion of migrants living in Europe. What's really important, and I think this will be a theme throughout my whole presentation,
We don't hear you anymore.
What the fuck?
So I guess we have maybe a bad connection. Okay, now could you turn on your sound, because we see the picture, but we don't hear you at the moment.
Oh, can you hear me
Right, now perfect, you're back. Thank you.
Okay, sorry. So what I think is really important is that there is enormous diversity depending on where you live or which country you're in, and the pattern of migration is very different in each country and, as mentioned before, in each canton. And so just a few facts about migration in Switzerland, that 33% of the population in Switzerland is foreign born. The majority of them are permanent residents in blue. And what you can see is that the top countries of origin for both permanent residents and non-permanent residents are primarily from Western Europe, as mentioned, as you can see in the two pie graphs, and about 15% are from outside of Europe. And so the top countries being Germany, Italy, Portugal, as Dr. Blatch mentioned. So in terms of asylum seekers in Switzerland, the profile is extremely different. And so you can see that Switzerland has received a large number of asylum seekers in the large movement in 2015 and 16, and now continuing on in the recent years as well, and that the top countries are extremely different for asylum seekers as they are for
We don't hear you. Do you hear us? There must be a problem with the connection. I hope
as
this
you
is
can
getting
see.
better. Yeah, now we hear you again. Sorry, I think there's a connection problem.
Can
Do
you hear me?
us?
Can you
Yes, we hear you.
Yes. So one of the things that is really important to consider when thinking about migration is that migration is an important determinant of health, and that there are many different stages of migration, and the events that occur at the different stages of migration drive the prevalence of disease and the outcomes of disease. So in the pre-arrival setting, in the countries of origin where migrants come from, they will carry with them the prevalence of disease and infections that are in their countries of origin. And this is driven by their access to care and treatment and vaccinations. And then the transit may affect as well the acquisition of infectious diseases, and depending on the type of travel conditions, if they're crowded, unhygienic, if there's violence and exposure to bloodborne infections, or if you're getting on a plane and it's a very easy journey. So the type of transit really will may drive exposure to different infections. And then the early and late settings in the host countries and how prepared the health system is to receive migrants. So in the early arrival, depending on the type of movement, if you have crowded reception centers that may be unhygienic because of large numbers of people moving, the importance of access to care and healthcare barriers, and then language barriers. And in the later settlement phase, the post-arrival, if there's screening and access to care and other potential risk factors. And then we won't even speak about this today, but there is the risks on returning back to people's countries of origin. So I think that one of the most important things to remember when you're considering the migrant population is that there's an enormous diversity among migrants across countries and within and across contexts. And this is driven by the country of origin of the person, the immigration class or socioeconomic status or transit conditions, ongoing mobility, and then as well is what are the post-arrival healthcare access and their entitlement and access to care, and how prepared our healthcare system is to receive these people. So across different countries, This is for the EU EEA and looking at infectious disease health disparities for migrants living in the EU EEA, which includes many different countries. And as you can see, that there are several different infections that there are health disparities for. And it really is driven by where the source country of where people are coming from. So you can see for tuberculosis, for example, that the proportion of tuberculosis cases that are occurring amongst migrants is 33% for tuberculosis, but there's an enormous range depending on the country and the host country. Similarly for hepatitis B and C, that there are health disparities related to hepatitis B and C, but with an enormous range, as well as HIV and vaccine preventable diseases. And these conditions are all important conditions because tuberculosis is a transmissible infection that is important to treat. Hepatitis B and C, as you well know, people in the room, of the liver-related morbidity and mortality and potential transmission as well, and HIV. So all of these conditions, these are infectious diseases that do have overlap within the same people, and you may have people that have both tuberculosis and viral hepatitis. So it's important to be thinking about multi-disease screening and how we may be promoting health by considering all different prevalent infections. Within Switzerland, the similar, looking at the different conditions, that tuberculosis is primarily among the immigrant population. Hepatitis B, as has been mentioned by Dr. Blatch, the majority of cases of hepatitis B also occurring among the immigrant population, and an important proportion of hepatitis C infections occurring among the immigrant population as well.
Will we get this connection back? Do you hear us? We don't hear you. Do you hear us?
Primarily in tropical and temperate countries. The prevalence of immigrants is about 12%. And this is an important condition because in an immunosuppressed host, if undetected, this is a lifelong infection that's easily treated that has a very high mortality. Schistosomiasis, many people in Europe are aware of this over the last 10 years, that this infection, which is primarily in Africa, and causes chronic urinary and hepatic disease, but eggs can be excreted in the urine and can be entered into the ecosystem in Europe, into the water or into the environment in temperate climates that has the vector. And so there are endemic areas now in Corsica for schistosomiasis that has been imported by either travelers or migrants. And then Chagas disease is another important condition that really is very focally focused in migrants primarily from Central and South America. So the question is, screening for infectious disease in migrants, why should we screen? And I think that there's a number of reasons to consider why we should screen, and it is to promote the health of the individual and to decrease the burden in health on the healthcare system in host countries, to prevent spread to host populations, which occurs not as commonly as people would think, and then spread to host environments, as I mentioned, for schistosomiasis. And so deciding to screen really depends on the epidemiology, the burden of the disease, if there are tests that are available to detect asymptomatic disease, interventions that are available that can treat and decrease burden, and then the health impact, the cost effectiveness, the care cascade, but also the health system preparedness that we'll talk about a little bit more. So implementing infectious disease screening, you really need to think on on a broad based level, and that you need to have screening guidelines. You need to have some sort of screening programs, and you need to make physicians and practitioners aware of what they need to be screening for. Patients need to be aware. Your health system needs to be prepared for this and prepared for screening, which for the migrant population would include having interpreters and culturally adapted health services, and services that are easy to navigate with ideally integrated care models with universal access to care. And so in 2018, the ECDC produced some guidelines on infectious disease screening and vaccination for migrants, primarily in response to the large movement of migrants into Europe in 2015 and 16. And I had the privilege of being involved with developing some of these guidelines. And so the screening guidelines from the ECDC do recommend for active tuberculosis, given this is a prevalent condition, to be screening for active and latent TB for people that are coming from high TB incidence countries, for HIV, if the prevalence is greater than 1%, or if there's risk factors, for hepatitis B and C at a threshold of 2%, prevalence for hepatitis B surface antigen, and for seroprevalence for hepatitis C of 2%, for schistosomiasis from areas where there is a high prevalence of disease, strongyloides much more broad-based, and to update vaccination. And one of the issues that really was highlighted in these guidelines was the importance of addressing implementation issues and ensuring linkage to care and treatment. Because if you screen, you have to make sure that you benefit from the outcome, which is supporting that individual through the care cascade, as well as treatment completion to have the improvement in health outcome. And so there are a number of infectious disease screening guidelines. I just put a few here to just sort of illustrate that there isn't great, there's very many different approaches to tuberculosis. We screen in the US and Canada and the UK prior to arrival. The ECDC is post-arrival. And in Switzerland, and the people on the ground will be able to fill in some of the gaps, but what I could find is that in Switzerland, the screening is voluntary for asylum seekers. And what there seems to be relatively heterogeneous or homogeneous agreement on screening for HIV and hepatitis B and C, but for the other conditions not, and that most people agree that we should be updating vaccines. The issue, though, I think that is with any guidelines is the gaps in implementation. So this was a report from the WHO European region that was recently published on the 53 countries in the WHO European region. And just about a quarter had guidelines for TB and HIV. Very few, only 6%, had guidelines for migrants on screening and care for hepatitis B and C. And what was highlighted is even if guidelines existed, even though there were a few guidelines, there was often a lack of implementation and a lack of awareness by healthcare practitioners. And the issue is, in terms of the barriers related to implementation, is that it's complicated and it really requires a multi-sectoral approach. And that the barriers are at the level of the patient, the provider, the health system, and the political legal aspect. And so you'll hear more about this and some of the details of some of the barriers that patients and providers encounter when they are accessing care. But for the patient, there's primarily the language and cultural barriers, navigating a healthcare system that they're not familiar with, and then sometimes not the ability to, or the flexibility to be able to leave work to attend clinic visits, the stigma related to the disease, and then fear and discrimination, as well as entitlement to care. And providers are often busy. They may lack the knowledge of the diversity of the migrant population and who should be screened or what tests to order, the lack of awareness of entitlement to care, and then as well, very busy schedules and lack of time. And in the health system, our health systems often lack interpreters, the supports that migrants require to be able to navigate the system, multiple steps in screening tests, complex screening, testing procedures, etc. And some of the facilitators, and I hope that you'll hear some of the solutions that have been put on the ground in Switzerland, is providing interpreters, health system navigators, educating practitioners, and strengthening our health systems so that we have migrant responsive health systems. And so let's move on to viral hepatitis, which is the main focus of the people of this audience, and that everybody here knows that in 2006, the WHO called for the elimination of viral hepatitis as a public health threat because of the increasing mortality due to viral hepatitis, eclipsing that of HIV, malaria, and TB, and the
Stay at the top of it.
Okay, we don't hear you.
the remaining cases of hepatitis C, where there's persistently high levels of hepatitis C mortality for the past 15 years, that are about 5 times as high as that of HIV, that 30% of cases of hepatitis B and C are not diagnosed, and treatments have been decreasing since 2018. So to be able to reach elimination targets, as are outlined, that the numbers of people diagnosed and treated need to increase, and the migrant population are an important population to be considering. So the epidemiology of hepatitis B in Switzerland that has been mentioned already, and this is cobbled from many different sources, and some of this data is a little bit outdated, but Switzerland is a low prevalence country, and about 75% of cases are occurring in the migrant population. Similarly, in hepatitis C in Switzerland, that prevalence is relatively low, and about a third of cases are occurring in migrants. And in terms of chronic hepatitis B and thinking about chronic hepatitis B, the prevalence of hepatitis B reflects that in their countries of origin, and it changes over time and has been changing over time due to vaccination. And as you can see, this is a systematic review led by my team about 10 years ago that really showed that the prevalence of hepatitis B really reflects that in their countries of origin, with the highest regions being as listed in Africa and Asia, and transmission occurring primarily at birth and childhood. And hepatitis B is important because immigrants bear a disproportionate burden. And in Switzerland, there's an increasing proportion of cases in the foreign-born from non-European origin that has already been mentioned. And international data of mortality related to viral hepatitis and hepatocellular carcinoma show that mortality among immigrants is 2 to 4-fold higher, and hospitalizations in Canada related to hepatitis B is 2-fold higher in the migrant population, so an important burden. Hepatitis C is a much more patchy disease, but in a systematic review led also by our team, the overall seroprevalence for migrants was about 2%, exposure primarily due to contaminated blood products and unsafe medical practices. And the proportion of hepatitis C occurring in migrants, as mentioned in Switzerland, is about a third of cases, and more in intravenous drug users than in other countries. And again, the disproportionate burden of hepatitis C in migrants really varies by the pattern of migration in each country. And in Canada, are hepatitis C among migrants. They're older and have more advanced liver disease at the time of diagnosis and the risk of end-stage liver disease. And so this is some data from linked databases in Quebec, where I practice, of almost 40,000 cases. And what you can see is that the hepatitis C rates among migrants as compared to the Canadian population has a relative risk of 1.6 to up to 4, depending on which region of origin people are from. Which is quite different than the immigration pattern in Switzerland. We also looked at the care cascade in migrants in Quebec, and what we found in the pre and post DAA era that all steps along the care cascade improved after introduction of the DAA therapy, that migrants were as likely to be linked to care, and that migrants were more likely to initiate therapy as compared to non-migrants. And similarly, in France, in a low-income population of primarily asylum seekers, many who did not speak French, that the care cascade, if migrants were well supported, actually was quite good. And it showed that supporting people through the care cascade with culturally appropriate individual or healthcare providers would have good outcomes. And so data from Switzerland or from Netherlands has shown that it is cost effective to screen for both hepatitis B and C at 2% and 1.5%, and that screening for both hepatitis B and C was cost effective, and you could screen for both. And that it was, if your hepatitis B prevalence was 1% and hepatitis C was 0.5%, that screening was cost effective and below the 20,000 QALY mark. So what is the optimal screening setting and testing method? And there are many different strategies that have been tried, and I'll try in the last 5 minutes to walk you through different strategies that have been tried in the community-based setting, primary-based setting, and the type of testing that might be effective. And so there have been different programs for viral hepatitis and linkage to care that have been very successful. Both 10 years ago, the Hep Screen and the CDC Hep TLC that was able to achieve good screening uptake and good linkage to care. And the EU-funded Hep Screen project, what they used was, this was a project where there was screening in different countries in different settings with culturally and linguistically matched healthcare workers. And what they found that opportunistic screening was more effective than outreach programs. And that with the CDC programs that, again, they also had outreach with bilingual care navigators. And what they found was that they had very good linkage to care, screening uptake and linkage to care. And this they attributed to strong community relationships and linguistically appropriate outreach and support. And so you can achieve high uptake in screening and linkage to care in the primary care setting if you support people culturally and linguistically, and with point of care testing is another strategy that has been successful. And this actually supports what we found in our care cascade, that you can get even with undocumented migrants in Italy as the top study there, and with migrants in with Médecins du Monde, that you can have a good uptake if you support people through the process. And that integrated multi-disease screening in primary care is both acceptable and feasible, and that you can have high uptake of hepatitis C among migrants in both the pre and post DAA era, supporting our data and our care cascade as well. And this is a study, the top study is in the UK, where there was good uptake of treatment of over 80%. And in a Canadian study as well in the pre and post DA era, there was good uptake. One of the other really important aspects of ensuring that there is uptake of screening and linkage to care and treatment completion is educating practitioners and reminding practitioners to screen, because practitioners may have low knowledge of which migrants to screen. They may not know the entitlements to screening. They may have language or cultural barriers. And as mentioned earlier, that practices are busy, and that for the overall, for hepatitis C, that putting reminders in the electronic medical records increases screening. And in a recent study that was done in Spain, that was a pragmatic RCT in 8 primary centers in Catalonia, Spain. What they found was that with a reminder in the EMR of multi-disease screening based on the person's risk profile, that screening increased by 1.3-fold. However, absolute screening was, the increase was relatively low, but this was feasible, and this is an adjunct of what strategies to improve screening. So in terms of the strategies to increase screening and linkage to care among migrants, that opportunistic, taking the opportunity to screen during health visits may be more effective than community-based outreach. In certain settings, that multi-disease screening in an integrated setting in primary care is quite effective. That point of care testing and multi-disease point of care testing is an interesting strategy, and adding reminders and integrated tools is important to educate practitioners. And some of the key facilitators, and I'm sure you'll hear more this afternoon, is the importance of engaging with community-based organizations and having outreach workers, health system navigators, and having systems that are linguistically and culturally adapted. This is from a recent report from the WHO, which just highlights all of the things that I've just mentioned, the importance of building refugee and migrant sensitive health systems, that the service delivery needs to be adapted, that you need to educate your health workforce, that migrants need to have access to medical products and vaccines and screening tests. Health information systems need to include migrants as a variable so that effectiveness and outcomes can be measured. You need leadership and governance to produce the screening guidelines, and then obviously the financing. And so very similar to what Dr. Blatch said, that one size will not fit all in host countries or for migrant communities. And because there are differences
Again, Ihr Standardmikrofon wurde geschaltet zu MacBook Pro. Ich was start. We have a problem to hear you at the moment. Do you hear me? Hello.
So to end, the global really is local, and I think that we need to continue to have the discussions and develop our systems so that we can improve the health of the migrant population, as well as decrease the burden on our health systems. So thank you very much. And I don't know if there are time for questions, but I'm happy to answer any questions if there are any questions.